Right.
Yeah. Very happy, sir. Very good initiative by Triple T
Okay.
branch. Doing great academic. We have to appreciate.
Allah.
நாராயணசாமி
சார்
என்னப்பா
ஸ்டார்ட் இட் சார்.
சார் ராஜேஷ் எல்லாம் நீ கேட்டுக்கோ
சார் அவர் இது ஒரு இதுல இருக்காரு. ஜாயின் இன் 2 minutes சார். So
Present.
we have so many people, important people are waiting. So I'm just one second sir, just checking who are available.
சார் விடிஆர் மட்டும் அப்படி கூப்பிட்டுருங்க, ஆரம்பிச்சு விட்டுருவோம்.
ஆடிபிளா இருக்கா சார்?
ஆடிபிள் சார், ஆடிபிள்.
சரி.
Humbly request everyone to hold on for the 2 more minutes. We will start the meeting in 2 minutes sir, please. to good evening to respected National President Sir, State President Sir, State Office Bearer, and Senior Patrons from IAP TTT branch. On behalf of IAP TTT, I cordially welcome you all for our first online case presentation meet. We have started it in the name of Tamira Guides, as Tamira Barni guides always get everyone to in a nice path. I personally chose this name, Tamira Guides, and we'll assure you that we will continue this activity very frequently, and we also expect the support from the state and of course state office bills have always been our great support, and request them to extend their full support to all our academic activities. So may I humbly request the if Singaravelu sir, are you ready to address, sir, or will you can address later, sir? So I think Dr. Singaravelu is just at the verge of landing. May I humbly request the state President IAPT and SC Dr. Homasundaram sir to share a few words, sir.
Yeah. So good evening and thank you IAP TT office bearers, Dr. Rajesh, Dr. Narayanasamy and Dr. Vivek for inviting me for this Tamira guides. So respected dignitaries on the stage, senior pediatrician Dr. Raju sir, Dr. Aziz sir, and our state joint secretary operations Dr. Manikavasam sir, our state EB member Dr. Sivanarayanan, and many other IAP members and senior pediatricians, and Dr. Singaravelu sir is there. Sir, Singaravelu sir, our central IAP president. Sir, Singaravelu has joined. So let us finish and then I can go ahead, or?
Yes, that will be better.
Sir, good evening. Good evening.
Good evening, sir.
So,
Good evening, sir. Sir, the entire forum.
they called you to
The entire forum
address,
is
but
Sorry,
waiting
sir.
for your
Just
address, sir. Please.
okay. Just if you don't mind, just I'll finish 1 minute.
finish பண்ணிடுங்க சார். நீங்க finish பண்ணிடுங்க, then I-
the signal there. Okay.
Yeah,
Good evening to all. At the outset, I thank each and every one of you for giving me this opportunity to serve as our national president. It is all because of you, your hard work. Today's guest of honor, State President Dr. Somasundaram, Senior Pediatrician of our TT, Dr. Aziz sir, Raju sir, and President, my good friend Rajesh, Narayanasamy, Vivek, Sivanarayanan, and all the team members, Ajay, those who are involved. I know the academic.
Sir, sir, your audio has been muted. Can you?
Now is it audible? Now is it audible?
Yes, sir. Audible,
Yes, sir.
sir.
Yes, sir.
Yeah. Sorry. So I'm sure that this academic program will go on very well. And today, Lima Pali Madam is known for her and the moderator and the speakers. Definitely, it will be a very good initiative. I am sure that this will spread the message and please pass on the message throughout India. So definitely, all will be benefited, and we will also try to guide and help you what best as possible. So, without wasting much time, I thank each and every one of you for giving me this opportunity. And my personal thanks to Somasundaram sir, our state president. In the middle of his talk, I intervened because of the connectivity issue. All the best. Over to Somasundaram sir. Thank you all, sir. Thank you.
For in
Thank
spite
you,
of
Singaravelu,
your busy schedule, traveling 3 flights, 2 flights, and then train, and then you have joined on this meet and expressed your appreciation to TT branch. So, shall I continue? Yes, sir. So I was so I have addressed everybody. So it's my pleasure to be with my so actually, so I'm an alumni of TVMC 1993 batch. So it's always close to my heart. TT branch is always close to my heart, and many are my seniors here in this in this forum, and there are few juniors also should be there in this forum. So it's very glad that yeah, district branch. So when I was there as the president of Chennai City branch last year, so we did the virtual Gurukulam. The virtual Gurukulam is the like Guru, Shishyan, and all this in the format. And 11 sessions were conducted with the Dr. S. Balasubramaniam as the scientific convener. It is very good that another district branch is taking over uh, with the initiative of encouraging and enlightening the postgraduates in the name of Tamira Guide. Definitely, this Tamira Guide is it will be like another corner guide for the for the postgraduates, and wish you all the success. And I believe Dr. Lima Palin Madam, our senior pediatric neurologist from ICH, Madam is also here. So Madam's like a vast knowledge will definitely be an asset to the practicing pediatricians and also to the postgraduates. With these words, without wasting time, I'm very happy to be with you in this inaugural event of Tamira Gates. Thank you very much for this opportunity.
Thank you so much, Sundaram sir. We are humbled and honored with your presence. And thanks for accepting our invitation, sir. I think 50 more than 50 people have joined. May you know any other state office bearers have joined, sir? I am not able to appreciate. Sir, good evening, sir.
Good evening, Narayan Sami. Good evening, everyone.
Good evening, Rajesh sir.
Sir,
Good evening. We already addressed. Okay,
Yeah.
thank you. All the best.
evening.
All the best.
Admission கேசிட்டு வந்திருக்கா admission கேசிட்டு வந்திருக்கா
Humble request Iap Ttt President Dr. V.T. Rajesh sir to share our words if he is available to speak. Sir, can you sir?
What? Yeah. I
welcome our chief guest, sir.
Yeah, I welcome all of you, one and all. First of all, I welcome our own President elect Dr. Singaravelu, National President elect, and our state OB team, members, President Sundaram sir, Secretary Dr. Narmada, Treasurer Dr. Raj Kumar, and past President Professor Rajendran, and President elect Dr. Thiru, and they are the Central EP members. I also welcome my friends Dr. Manikavasam and Dr. Shivnarayan and state EP members. I welcome Professor Lima Palin for her dedicated contribution to pediatric neurology to be among with us to guide us. I welcome Dr. Babu Kandakumar, Professor of Pediatrics, Tirunelveli Medical College. I also welcome Dr. Anand, who is going to moderate the session. And the most important, the presenter, Dr. Sanjeevita, a DNB first final year PG from Krishna Hospital. I also welcome my own team members, secretary and treasurer. Also all the IAPNs, senior IAPNs.
DBF sir சொன்னது
Dr. Raju is here, Dr. Tirumali Kolondu sir is here. I welcome all the IAPNs and also PG student. And this is the first ever maiden Zoom meeting from our branch. And I thank our secretary for all the initiatives he has put forth within the short period of time. And I really thank him and appreciate his efforts. Thank you, one and all.
Thank you, sir. Thank you so much. And I have seen Professor Dr. Rajendran sir, State President 2025, IAP TNSC. May I humbly request Professor Rajendran sir to share a few words, sir.
Thank you, Dr. Swami. I think Dr. Singaravelu sir is there and President Dr. Somsundar is there. After that, I will talk.
Sir, we just finished addressing, sir.
Okay. Thank you.
Yeah,
sorry. I came
good evening,
late.
sir. Good evening, KR, sir.
Good evening. Most respected our President-elect National, Dr. Singaravelu sir is coming from all the way from Nagpur and is now Chennai. On behalf of IAP TNSC, I welcome, and because of Triple T, I welcome Dr. Singarvel sir and most dynamic President Dr. Somasundaram, President-elect Dr. Tirumurugan, and Secretary Dr. Narmada and Treasurer Dr. Rajkumar, and most dynamic Joint Secretary and Operations Dr. Manika Vasagam, and EB member Sivanarayanan. And I think this is apart from Chennai, this second district branch, they are doing a postgraduate presentation. I really appreciate the leadership of Dr. Rajesh and Dr. Narayan Swami, Dr. Vivek. They are taking innovative ideas at the district level. And it is almost now 65 delegates joined. It's a wonderful initiative by Triple T branch. And stalwarts are here that I can say Dr. Raj sir, and another thing is my friend and batchmate Dr. Arunachalam, Babu Kandakumar, and everybody is here. I think definitely it will be a useful program for postgraduates. And on behalf of IAP TNSC, and I wish my Gati wishes to Triple T branch. Thank you very much. And they can do better programs in future also, or program also. Thank you very much. Yeah.
Thank you so much, Professor Rajendran sir. We are honored with your gracious presence, sir. May I humble request Dr. Tirumurugan sir, the State President-elect 2027 IAP TNSC.
Thank you very much for this wonderful occasion. Actually, I think I have always been a big fan of education being spread at various levels, and I'm really delighted that IAP Triple T branch has invited me to join them on this quest to develop the pediatric postgraduate education. As you all know, I think the TNSC has been in the forefront for the last 5-6 years, and we have done the 125th episode just last week. So it's really nice. Actually, the knowledge is getting transferred even more, and I'm really I would like to really offer my best wishes to the Triple T branch, because they are one of the larger branches of Tamil Nadu, and they deserve to take their branch to the next level. They did that with the Tamira Pedicon, and I'm sure with these kind of programs, they will do even better. My special wishes to Dr. Rajesh, Dr. Narayanaswamy, and Dr. Sivanarayanan, and all the other team members, Dr. Tirumala Kolundu, and all the other team members who have taken this initiative to develop their branch further. Thank you very much for this wonderful opportunity.
Thank you, sir. Thank you so much, sir, and for your presence and your great words. May I humbly request the Honorary Secretary of IAP TNSC, Dr. Narmada ma'am, to share a few words.
Thank you so much for inviting me to be a part of this wonderful venture. The TTT branch always sets a new standard, and we all know that through the Tamira Pedicon, it's really amazing that more than 65 people have joined on the Zoom platform. When everybody is complaining about the attendance being very poor, this really shows the commitment and the academic excellence of IAP TTT branch. I'm greatly honored by for having invited me here. And I really wish you take the program and much more physical programs also to a greater extent, inviting many people. Senior academicians like Raju sir, Tirumala sir are all here to impart the best of the knowledge. And we also have very enthusiastic office bearers like VT Rajesh sir, Manika Vasagam sir, Sivanarayanan sir, and also juniors like Narayan and Ajay, who are going to lead IAP TTT. I'm really honored for having invited me. And it's always like we keep going for the physical program, and it's wonderful to see the first initiative. Thank you so much, and all the best. Please come out with much more interesting programs. We will also have fun joining with you. Thank you.
Thank you so much, madam. Sir, Dr. Rajkumar sir, Secretary, IAP TNSC, is he available, sir?
Sir,
Rajkumar sir.
I think Rajkumar sir கொஞ்சம் வெளியில இருக்காங்க, out of station சொன்னாங்க actually.
Okay, sir, no problem, sir. Okay, sir, thank you. request the Joint Secretary Operations IAP Manikavasakam two words, sir.
Good evening, all, and respected chief guest of this evening, our national president-elect Dr. Singaravelu sir, our Tamil Nadu president Dr. Somasundaram, past president Dr. Rajendran, and president-elect Dr. Tirumurugan, and secretary Dr. Narmada, and treasurer Dr. Rajkumar, and esteemed senior faculties Dr. Tirumali Gunundu, Dr. Raju, and Dr. Rajesh, and dear colleagues and postgraduate students. It is a pleasure to be part of the inauguration of Tamira Guides, an academic initiative under 2026 Presidential Action Plan of Iap Ttt. Postgraduate education today requires clear clinical reasoning and exam-oriented preparation and guidance from the experienced mentors. Tamira Guides is envisioned to provide exactly that through the structure and focus case discussions. Beginning the series with a CNS case on spinal muscular atrophy reflects our intent to address relevant and evolving pediatric topic is essential for postgraduate training. We are honored to have eminent senior professors Dr. Lima Pauline, Dr. Babu Kandakumar, and Dr. Anand guiding this session, and I am confident their insights will greatly benefit our postgraduate students. I congratulate and the organizing team, my own TTT President Dr. Rajesh, Secretary Dr. Narayanasamy, and Treasurer Dr. Vivek, and encourage all postgraduates to actively engage and make the best use of this academic platform. Thank you.
Thank you so much, Manikavasakam. We literally want to have a word from each and everyone, but due to shortage of time, we'll have the few words from our state EP member, Dr. Sivanarayan sir, to have a thankful message to all the delegates who are presented, and also to introduce Professor Dr. Lima Pauline, Madam, sir.
Good evening to one and all. On behalf of the IAP TTT branch, it is my proud privilege as State Executive Board member to propose the vote of thanks for this memorable inaugural session of Tamira Guides, the Presidential Action Plan 2026 initiative. First and foremost, I express our heartfelt gratitude to our chief guest, Professor Dr. Singaravelu sir, National President-elect IAP 2027, for his gracious presence and inspiring inaugural address. Your visionary words have motivated all of us to strengthen postgraduate academics through this platform. I extend my sincere thanks to our esteemed guest of honor, Dr. Somasundaram sir, State President IAP TNSE, Dr. Narmada Madam, Secretary IAP TNSE, Dr. Rajkumar, Treasurer IAP TNSE, Dr. K. Rajendran sir, State President 2025 IAP and Central EB member, and Dr. V.T. Tirumurugan Siran, State President-elect 2027, Dr. Manikavasakam, Joint Secretary Operations, and our senior colleagues, Dr. Aji sir, Dr. Raju sir, and Dr. Tirumali Gunundu sir. Your continuous guidance and encouragement have made this initiative possible. My special appreciation to our dynamic TTT leadership, Dr. V.T. Rajesh, President IAP TTT, the driving force behind Tamira Guides, and Dr. S. Narayanasamy, Secretary IAP TTT, and Dr. G. Vivek, Treasurer IAP TTT, for their meticulous planning and commitment to postgraduate education. I also thank the organizing academic team, technical support team, and all postgraduates who have joined today with enthusiasm. A special word of gratitude in advance to our respected professors, moderator, and presenter who will take forward the academic session. Finally, I thank everyone, every participant who has spared valuable time on a Sunday evening to be a part of this learning movement. With your continued support, Tamira Guides will grow into a stronger academic lighthouse for our region. Thank you all. Jai Hind, Jai IAP.
I humbly request Dr. Sivanarayan sir, as we are about the session, I humbly request Dr. Sivanarayan sir to also welcome our professor, Dr. Lima Pauline, Madam, sir. Please.
Respected seniors, dear colleagues, and my beloved postgraduate students, it is my great honor and personal privilege to introduce our esteemed expert for today's session, Professor Lima Pauline, Madam. I am especially happy to introduce her because she is not only a renowned pediatric neurologist, but also my classmate and batchmate during our MD Pediatrics at Madurai Medical College. Even during our postgraduate days, she stood out as an exceptionally studious, extraordinarily brilliant, and deeply committed clinician, qualities which later shaped her into one of the finest teachers in pediatric neurology. She completed her MBBS from Madurai Medical College, MD Pediatrics from Madurai Medical College, DM Pediatric Neurology from prestigious Madras Medical College. She carries an impressive 25 years of experience in pediatric neurology with special interest and expertise in neuroimmunology and neurometabolic disorders. Throughout her career, she has been admitted for her sharp clinical reasoning, compassionate care for children, and remarkable ability to teach complex neurology in a simple and exam-oriented manner. We are truly fortunate to have your guidance today on the important topic of spinal muscular dystrophy, atrophy, which is highly relevant for postgraduate training and clinical practice. On behalf of IAP TTT and Tamira Guides, I extend a warm and affectionate welcome to Professor Dr. Lima Pauline and request her to kindly take over the session. Thank you.
Good evening,
so much,
everyone.
sir.
And I thank Dr. Shivanarayanan and IAP for this wonderful opportunity. It's always our pleasure to teach our youngsters.
Thank you so much, madam. We are really humbled with your presence. Also, welcome our Professor and HOD of Thuthukudi Medical College Pediatrics, Professor Dr. Arunachalam sir, for his immense support towards he is also a dynamic IAPN, let's say, and thank you so much, sir, for your presence, for including all your PGs to this IAP. Thank you, sir.
Congratulations, IAP TTK, for your wonderful efforts, sir. So, best wishes for your future programs also.
Thank you so much, sir. And I also humbly request the senior pediatrician of Tirunelveli and the patron of IAP TTT branch, Dr. Raju sir, to welcome our another professor of today's session, Dr. Babu Kandakumar sir.
Good evening, the President IAP Central, President IAP State, Secretary, incoming President, Treasurer, and the President of our own TTT, Dr. VTR, and the dynamic Dr. Narayanasamy, Dr. Vivek, the Treasurer. Thank you very much for the opportunity. I am asked to give an introduction about Dr. Babu Kandakumar, whom I fondly call as Dr. BKK. He is a renowned pediatrician, professor, and in the department of Tirunelveli Medical College. And he had been a mentor, role model, and an inspiration to many budding postgraduates. His excellence in academic knowledge sharing and passion for tracking the postgraduate and UG students is adorable. He did his MBBS in TVMC and DCH in Madurai and MD in Madras Medical College. He has rendered his service at Tirunelveli, Tuticorin, and Madurai Medical College. He was the divisional coordinator IAP PG quiz in 2023, and he has been a renowned faculty for MRCP 2019, Neocon 2019, Sangam Pedican 2019. He has received Best Doctor Award in 2018-22 and ST Archer Endowment Award in Pediatrics in October 23. It's a boon for the students to include Dr. BKK, Dr. Babu Kandakumar in this group to enrich the knowledge of the postgraduate. And I congratulate all the office bearers of the TTT. Within a short time, they arranged a big thing, and I wish them to continue the same in future. Thank you.
Thank you so much, sir, Dr. Raju sir. So let's start this session. But before that, may I humbly request Dr. Vivek to welcome our moderator, Vivek, the treasurer of IAP TTT branch, to welcome our moderator, and Dr. Anand sir, and followed by Dr. Anand will take over this session. Vivek, over to you.
Good evening, respected Singaravelu sir, National President-elect, Dr. Somasundaram sir, Dr. Narmada ma'am, Dr. Rajkumar sir, Dr. Thirumurugan sir, Dr. Manikwasan sir, Dr. Sivanarayanan sir, and our respected senior pediatricians of Tirunelveli or patrons of IAP TTT, and my dear postgraduates. It's my pleasure to introduce today's moderator, Dr. Anand sir. He's a senior assistant professor from Government Tuticorin Medical College, and he is our academic coordinator. He's a highly regarded teacher among students. He has consistently contributed to strengthening our IAP academic activities. So I now invite Dr. Anand sir to take over the session as a moderator. Thank you.
Thank you so much, Vivek. I will be fair. Failing in my duty if I don't appreciate Dr. Sanjeevita, a very active and very intelligent postgraduate from Krishna Maternity Home Pediatric Hospital. And thank you for accepting to present a case, especially within a very, very short time. Anand sir, over to you, sir. Thank you so much.
Good evening, all. Am I audible?
Yes, sir. Yes.
Yes, sir. So, thanks for this opportunity. I'd like to thank all the office bearers of IAP TTT branch for having given this opportunity for me to moderate this session. And I'm very happy that two of my professors, both Lima Madam and Babu sir. Lima Madam was my teacher in Trichy when she was an assistant there. And Babu sir was my mentor during my post-graduation. So I'd welcome Dr. Sanjeevita. So let us start the session. Sanjeevita, can you share your slides?
Yes, sir.
Sanjeevita, can you please share your PPT, please?
Yes, sir. I'm doing so. Sir, is it visible, sir?
Yes,
Yeah,
visible.
Yeah, so can you try to put your phone in the landscape mode? So it will be visible in the full screen.
It's a miniature, it's visible as a miniature screen.
Yeah.
So full screen is not coming. Yes.
Yeah, now it is visible. Sanjeevita, you can proceed.
No. Good evening, everyone. Today I'm going to present a case on floppy infant. Baby X, a 5-month-old boy baby, second born of third-degree consanguineous marriage, hailing from Tirunelveli, was bought by his mother with good reliability, with chief complaints of not attaining milestones since birth, floppiness while handling the baby for the past 3 months, reduced spontaneous activity of the limb for the past 3 months, and difficulty in feeding over the past 3 months. Since it's the CNS case, I would like to present from the antenatal history. So the child is a second born of third-degree consanguineous marriage. Mother was married at 23 years, conceived spontaneously at 27 years with a pregnancy gap of 4 years. First trimester, pregnancy was confirmed by UPT at first week of missed periods.
While presenting this patient, initially you have to explain its chief complaint. Generally, you have to go to the antenatal history. Here, even though the patient is having all the problems started since infancy, the initial complaints are only not attaining milestones and floppiness. So until the age of 5 months, what are the important complaints? Try to explain, then go to the antenatal history and then proceed. That's the way of presenting a patient with a developmental delay. Main complaints are not attaining milestone and floppiness and reduced spontaneous activity. So up to the what age, what the problem patient was normal, and when the problem started, try to explain, then go to antenatal history. There's an ideal way of presenting this type of patient. Yes?
Okay, sir.
Okay, proceed.
So according to the mother, baby was normal at birth. After 2 months of age, she gradually noted that the baby had generalized floppiness while handling the baby, and the baby keeps slipping through her arms when held under the shoulder. She also noticed that the baby had reduced spontaneous movements of all the limbs over the past 3 months. Now the child is not able to lift the arm, but lifts his forearm and brings it to his mouth and sucks. And baby has a weak grasp and frequently drops the toys given to him. The baby doesn't kick his legs but moves his foot. The baby doesn't turn in bed nor hasn't rolled over. The baby turns his head to sounds with minimal neck movement. There is no history of drooping of eyelids or facial muscle involvement. No history of any diurnal variation of weakness. Baby looks around and recognizes parents and smiles at them. There is no history of seizures or letharginess. A baby has a weak cry. Baby has feeding difficulty in the form of coughing during bottle feeding and prolonged feeding for about half an hour. No history of nasal regurgitation of feeds or choking or vomiting or drooling of saliva or milk. There is no history of honey ingestion or any other drug intake. History of deformity of both feet and currently on POP casting. No history of squint or no history of squint or ptosis or any visual disturbances. No history of deviation of angle of the mouth while crying. No history of drooling of saliva or nasal regurgitation of feeds. No history of any. Sorry, ma'am.
Dr.
No.
Sanjivita, you have said that this is a 5-month-old child who has not attained any milestones. What are the milestones you expect to be at this age?
At around 3 months of age, I would
Now
expect
that the child has
control.
Now the child is 5 months completed, is it so?
Yes, ma'am.
Okay. So what are the milestones you expect that the child should have achieved?
Gross motor, there must be a complete neck control. Gross motor, there must be complete neck control, ma'am. Even when swaying the baby, there must be no head lagging or any movement. In fine motor, ma'am. Sorry, ma'am.
Social milestone.
Social milestone by 2 months of age, the baby must have social smile, and 3 months, the baby must recognize the mother.
Yeah. So, and the other complaint, so you should have told that the child has not achieved any milestone in the history of present illness itself, because that is the first complaint. Is it not? So you can explain in that also in your presenting illness.
Okay, ma'am.
That is number one. And number two will be, what is your second complaint, my dear?
Baby has reduced spontaneous movements of all limbs, ma'am.
Yeah, the second complaint is floppiness while handling the baby. That you have explained nicely. The child used to slip through the fingers, and the mother has noticed floppiness, and all those things. And the second, third, and all you have nicely explained. So first of all, whatever may be the complaints, you have to expand it, and you have to describe in detail in the history of presenting illness. Okay, then you go for the other things. Go to the next slide. Next slide. Next slide. Presenting illness. Previous, yeah. So here you have nicely pointed out that there was reduced spontaneous movements of all 4 limbs. Just like that, you cannot leave the line as it is. Or when the yeah. Yeah, tell me. You can say that there is some mother has noticed the reduced spontaneous movements of all limbs when the child is lying down on the floor or on the bed like that, and the child is not able to lift the arm but lifts his forearm and brings out. You were telling that the child was reaching for objects, but by 5 months and all, you can't expect that reaching for objects, is it not?
Yes.
And you can say whether the child, whether the baby is moving the lower limbs or moving the lower limbs in bed, and whether the child is able to raise the both the lower limbs off the bed. That thing you can say, okay? And you have nicely pointed out, doesn't turn in bed or not rolled over by 5 months also. And then you have brought out the cranial nerve history. That is very good. Yeah. And so your presentation should be like expanding or describing in detail about the complaints first, and from the complaints, what are the problems the child is having, and you have a floppiness or which is equivalent to your hypotonia, and you have to, whenever there is a tone abnormality, you have to find out whether there is a weakness or not. That you have brought out, and in both upper limbs as well as in the lower limbs. You have told that there is a proximal weakness, and there is a distal weakness as well in the upper limbs. That you have told. You have told that there is a history suggestive of a trunk muscle weakness. That also you have told. And then you have to go to the cranial nerve symptoms. And then you come back for the additional history. So your diurnal variation and all should come afterwards. Go to the previous slide, my dear. Go to the previous slide. Previous, yeah. No history of drooping eyelid. Next. That should be some order. Turns to the head sounds should come after your drooping of eyelid. Then next slide. This line should have come first. Baby looks around and recognizes the parents and smiles at them, which signifies or which denotes what, my dear?
Normal cognition, ma'am.
Normal cognition as well as vision as well. Okay, vision as well. Then you can say there is no drooping of eyelids or there is no abnormal posture of the eyeballs. Then you have to say there is no, then you come for your bulbar weakness. History suggestive of bulbar weakness. You have told that there is a history of difficulty in feeding. So you have explained there should be some order. Okay. Then only you can go for the etiological history. Always your history of presenting illness has two parts. One is describing the complaints and find out what could be the site of involvement. And then what could be the second part of the presenting illness should have histories which will tell us what could be the etiology. So do not mix up both. Okay. Your honey ingestion and another thing you have said. That and all should come later. That is your diurnal variation. All those things should come later. Yes, proceed.
And what about the clinical status of the patient during the first 2 months? During the initial 2 months, what are the clinical condition? Whether the baby was able to feed and was able to have a normal respiratory movement and everything, or during the initial 2 months, was there any problem suggestive of an early onset of problem? So you have to explain. So before 2 months, there was no respiratory problem, there was no feeding difficulty, and there was no other complaints like positive movements, other things. So all the problems, according to history, all the problems started by 2 months of age. Before 2 months, what about the child's condition? You have to explain, and what are the things to be explained in the well-being of the child? While explaining the well-being of the child, what are the things to be explained? What about the feeding pattern of the child? What about the sleeping pattern? What about the activity of the child? You have to get the history from the mother. The child was sleeping normally, and there was no history of anything abnormal during feeding. And also, child's and cry activity, you have to get an history so that the child is said to be normal prior to the onset of the problem. So here, the problem started by 2 months. After that, only all the problems started, right? According to history, that's better include the history during the initial 2 months also. Yeah, let's proceed.
No history of any involuntary movements. No history of crying while there is history of crying while receiving injections and vaccination. No history of abnormal breathing pattern or noisy breathing. No history of any excessive sweating or flushing of skin.
What are the type of movements often involved? Initial 2 months. Suppose you are keeping the baby by the side of the mother. What are the movements observed during the initial months, 2 to 3 months, and subsequently, what type of movement are observed?
During the initial months, there will be mainly reflexes, atonic neck reflex,
The common type
symmetrical.
of, suppose you're keeping the baby by the side and the baby is placed in a supine position. What is the type of movement you're observing during the initial 2 to 3 months, and subsequently, what is the type of movements observed? During the initial 2 to 3 months, the child always shows some involuntary breathing movement, which cannot be controlled by the newborn baby and younger infant. It is completely not under control. It is in the form of breathing involuntary movement. And after 2 to 3 months only, the baby attains some amount of control on the motor movement and shows smaller amount of small movements that is said to be fidgety movement. So involuntary movement, initial 2 to 3 months, child always shows involuntary movement which cannot be controlled by the younger infant. That is a normal movement. And after 2 to 3 months, fidgety movements are observed, which is a smaller round movement, and that is peculiar for this particular age. Right?
Okay.
So what are the involuntary movement expecting in this type of patient? There is no history of tremor. Tremor, a 5 months old child, is it possible to observe tremor? What are the other types of involuntary movement in this age, 5 months old child? Other involuntary movements like choreoathetosis, dystonia, all these things you can observe. But tremors, when the child starts doing some intention movement, then only we can observe the tremors in an easy manner. Or fasciculation is very difficult to observe in the peripheral muscles. Right?
Okay, sir.
Okay, right, proceed.
Coming to the past history, at 4 months of age, baby was admitted for loose stools in ward for 3 days only. At around 4.5 months of age, baby was admitted. Baby had cough and increased work of breathing, for which the child was admitted in PICU and was started on HFNC, IV antibiotics, physiotherapy. PICU stay was for a total of 6 days. Parents were informed that it was due to aspiration. Baby was on NG feeds during the stay. No history of recurrent lower respiratory tract infection. No other drug intake and supplements.
Okay. Okay. Then Pogotto, sir. She didn't come. She didn't pick the call also.
Coming to the antenatal history, baby is the second born
I
of
will
the
call her, sir.
consanguineous marriage. Mother was married at 23 years, conceived spontaneously at 27 years with a pregnancy gap of 4 years. At first trimester, pregnancy was confirmed by UPT at first week of Mr. period. She was booked and immunized at a nearby PHC. Dating scan and NT scan done were normal. No history of preconception folic acid intake, but took folic acid and calcium regularly after diagnosing pregnancy. No history of drug or any radiation exposure. No history of fever with rash or any excessive vomiting. Second trimester.
Pregnancy by UPT is not a correct statement. Pregnancy you cannot confirm by doing UPT. There are so many false negatives. For confirming pregnancy, you have to demonstrate the product of gestation in the particular sac. Then only you can confirm. So pregnancy confirmed by UPT is not a correct statement, right? So other things okay, right? Then second trimester.
Second trimester quickening was felt at 20 weeks of gestation. Fetal movements were perceived normally as during the first pregnancy. Mother took iron, folic acid, calcium supplements regularly. Anomaly scan was normal. 2 doses of tetanus immunization was given. No history of gestational diabetes mellitus, hypertension, hypothyroidism or anemia. No history suggestive of any urinary tract infection, bleeding, perineum or false spelling discharge. Third
What are the
trimester.
reasons for delayed quickening? Suppose the mother not felt quickening at the 20th week of gestation. What are the likely problems? What are the importance of quickening?
Quickening, it is perceiving the fetal movements by the mother.
Fetal movements, okay. Suppose the mother is not felt the fetal movements and fetal movement want to be reduced as per the mother's statement. What are the clinical possibilities?
Possibly polyhydramnios, sir. Then coming to the baby, there may
okay, polyhydramnios. Then
if there is any problem from the baby's side, such as
baby
any
said what are the
muscular,
problems? Baby said what are the problems?
SMA,
Okay.
SMA, congenital myopathies, congenital myotonic dystrophies, any other?
And also developmental anomalies of brain, as well as neuromuscular disorders of fetal onset. All are associated with reduced fetal movements, right? Okay, next slide. Third trimester.
Third trimester, she was able to perceive fetal movements well as during the first pregnancy. Growth scan was normal. No history of polyhydramnios or oligohydramnios was documented. No history of any GDM, hypertension, hypothyroidism, or anemia. No history suggestive of UTI, bleeding per vaginum, or false smelling discharge.
Which is more specific in patients with neuromuscular problem. Antenatal mother, which history is more suggestive of an fetal or neuromuscular problem. Polyhydramnios or oligohydramnios?
Polyhydramnios, due to difficulty in swallowing of the
Why there
amniotic
is
fluid.
increased incidence of polyhydramnios?
When the child has difficulty in swallowing secondary to
People may
any
not be in a
bulbar
position to swallow normally, right? Okay, good. Proceed.
birth history at 36
And
weeks of
also,
gestation.
one other important abnormal lie is also very common. Abnormal lie in the form of transverse lie and other abnormal malpositions are also more common in babies with a neuromuscular problem. So they may not be in a position to assume the normal position. So these are the important antenatal history.
Here the presentation was cephalic presentation. Sir.
Okay, right.
Birth history at 36 weeks of gestation, mother was admitted for labor pains. Baby was delivered by LSCS. Indication is previous LSCS. And baby cried immediately after birth. Baby birth weight was 2.1 kg. Baby was breastfed within 1 hour of birth. There was no history of NICU admission. Baby was roomed in with the mother at the day of birth itself. No history of neonatal seizures or hypoglycemia or no history of neonatal jaundice. Passed urine and meconium on day 1 of life. Developmental history, gross motor, head control is not achieved. Fine motor, the baby tries to reach out for objects and holds on to object only when it is kept on the hand. It brings the hand to his mouth. Language, cooing was achieved at 2 months. The baby squeals and laughs at around 4 to 5 months of age. Social and adaptive, social smile at 2 months of age, recognized mother at 3 months of age. Currently, the child has stranger anxiety. I'm looking at the
Normally, there is stranger anxiety is anticipated. Is it 5 months or
7
slightly
months,
older?
6 to 7 months.
Stranger anxiety is later, 6 to 7 months is an age at which stranger anxiety is commonly observed, not at 5 months of age, right?
So the interference. So here the inference is isolated motor delay.
Isolated motor delay.
Yes. Nutrition history. Child was on formula feed since birth. And the child had difficulty in taking feeds with prolonged feeding of around 30 minutes to 45 minutes per session. A baby has been started on complementary feeding for the past few days. There is a calorie deficit of 65 kilocalorie and a protein deficit of 1 gram, which is not significant.
5 months old baby started on complementary feed. Comment about
Only after 6 months of age, we have to start on complementary feeding.
After completion of 6 months, you have to start a complementary. Yeah, the baby is only 5 months old.
Yes, sir.
Right.
Immunization
Why
history.
the baby was started on artificial feed? Why not the breastfeed was on formula feed since birth? What is the problem?
Because the mother had reduced supply, baby was started on formula feed, sir.
There should not be a statement. It's reduced supply is not a correct answer. Baby was started on formula feed since birth. So there been some other problem in the baby. What are the problems of lactation failure? A problem in the baby. What are the problems?
Possibly due to poor sucking, there was decreased
Maybe
breast
problem with the
emptying.
baby, not able to suck the breast continuously or ineffectively. That's one problem with the baby, or having some problem in the form of palate abnormality, right? Is there any such problem? There's no such problem. Is there any such problem in the baby bar? So
No,
other
sir.
than form of foods.
So sorry, sir.
What about the sucking? Have you input about the sucking pattern of the baby?
The baby
mother?
had prolonged sucking, prolonged the feeding time. So
It's a
probably due
long
to
time that can be
sucking.
caused the baby. Right. Okay. Is there any cardiac problem? Is there any history suggest to any cardiac ailment in this patient?
No, sir.
Yeah. Yes. Proceed.
Immunization history. Immunized till date according to the national immunization schedule in the nearby PHC. 14th week vaccine was given. Next vaccine due at 9th month. No adverse reaction following immunization. Family history. The child is a second born of third degree consanguineous marriage. No history of neurological or any muscular diseases in family. The first child is of 5 years of age and is developmentally normal. According to a socioeconomic history, according to modified Kupasamy scale, the family belongs to the upper middle class.
So immunization still is anything relevant? OPV
According
and
to
patient presenting with paralysis, how will you correlate?
okay, sir.
Immunization history, what is the correlation between the OPV vaccination and presenting with paralytic future?
Derived paralytic polio, ADPP.
Vaccine?
Vaccine associated paralytic polio, DAPP.
Can also induce paralytic lesions. So late onset of paralysis following oral vaccination, if the patient is having features suggestive of classic paralysis, you have to screen the patient for polio also by doing stool examination and stool culture, right?
Yes, sir.
Okay.
The contact history, there is no history of contact with active case of tuberculosis. Allergy history, there is no history of allergy. Coming to the summary, the child, 5-month-old boy baby, second born of third degree consanguineous marriage, presented over the past 3 months with floppiness of all limbs and weakness, with proximal more affected than the distal and the lower limb more affected than the upper limb. A baby has feeding difficulties with prolonged feeding period and cough during feeds. The baby has also a weak cry and also has a past history of PICU stay for aspiration pneumonia. Inference is probable hypotonic weakness, predominantly proximal with and lower limb involvement predominantly, with respiratory muscle weakness and palatopharyngeal incontinence, with intact cognition, probably due to a peripheral cause.
The lower limb more affected than the upper limb. That is the statement.
Yes, sir.
Right? Lower limbs more affected and
Affected
proximal
than
with
upper.
weakness more.
Yes, sir.
How do you get an history of lower limb weakness more affected than the upper limb?
Child is able to bring his hand to his mouth, sir, but in the lower limb, the child is not able to kick his legs. Only is able to move his feet.
Okay, right, good, right.
Again, bringing the hands to the mouth is only elbow movement is along gravity. It is not against gravity. So you can say that child is whether the child is able to move both the lower limbs in the bed sideways or other that also is absent, or that also history wise that is also not there.
Only sideways the child was able to move, ma'am.
That is again 2/5 only. Then you can say that there is an quadriparesis, flaccid quadriparesis, you can say. And in the upper limbs, you have said weak grasp as well. That means there is a distal weakness as well. So in the examination only, you have to confirm whether that the proximal is more involved than the lower limb like that. And you can add on in the history itself whether there is no any history of seizures. So that also will help you to classify whether it is a central type of hypotonia or a peripheral type of hypotonia, all those things. Okay.
examination.
Yes, my dear, to the previous slide. So your from the history, your conclusion will be
Peripheral causes of peripheral.
here is a
Peripheral
floppy
hypotonia.
infant. That's what you have to
Floppy.
say. Floppy infant. Okay. Here is a child with a floppy infant with a quadriparosis neck. The child has not attained head control as well. Child is not able to turn over. That means the child is also having a neck weakness as well as a trunk weakness. That also you can include apart from the flaccid quadriparosis. Okay. With the preserved sensation, you have to say, because in the history itself, you were reiterating that the child was able to cry whenever the injections are given. That also you can. And with the intact higher mental functions, or the child has achieved the social smile, recognizing the parent, all those things you have to say. So you have said, so it is with the intact cognition and apart without any history of seizures. So I am thinking in terms of peripheral causes, like that you have to say. Okay, fine, proceed.
Coming to examination. On general examination, the baby is alert and is interested in surroundings.
And again, one more thing. In the peripheral causes, you have said that the anterior console or the nerve or in the neuromuscular junction. But lastly, you have put out that one. That is metabolic cause. That you need not say. What is that metabolic cause? Your possible involvement, you have said that it's a peripheral causes or LMN involvement. And among the LMN involvement, you are considering anterior console, muscle, and the neuromuscular junction as your differentials. Okay?
Okay, ma'am.
Next.
Coming to examination. General examination, the baby is alert and interested in surroundings, interacting with parents with a low volume cry. Attitude, the baby is lying
What does it
supine.
indicate? The low volume cry, what does it indicate?
A weakness of the intercostal muscles and the pharyngeal muscles.
So volume of cry also indicates the patient's tidal volume. So if there is a reduction in tidal volume, the volume of cry is also reduced. So there is an history clinical examination. One of the findings suggestive of a respiratory muscle weakness is the low volume of cry. Yes, proceed.
Attitude, the child is lying in supine position with hip joints abducted and externally rotated. The knees are flexed and the lateral surface of the lower limb is lying on the bed. Shoulder is abducted and extended.
What's the name of the posture? Is there any specific name? Lying in supine position, it is abducted.
Externally rotated.
Externally rotated. What is the other name? The frog-leg position. That is indicative of right. Okay. Frog-leg position. Right. Okay.
Shoulder is abducted, externally rotated, and arm is mostly lying on the bed, and elbows are flexed. One hand is lying on the side of the head, and the IV line hand. The other hand is in the mouth.
Normally, 5 months old child, the normal child, so placed in a supine position. So, what are the common things observed? 5 months old child. Here, the child, shoulder abducted, external rotated, arm is mostly lying on side with the elbows flexed. Suppose a normal 5 months old healthy child, we are keeping the baby in a supine position. What are the things to be observed?
The limbs will, lower legs will be off the bed, sir. And they will bring the leg to mouth and bring the hands to mouth. And they'll try to roll over.
Okay, there is possibly there should be movements on both sides, must be equal, and universal flexion is initial attitude. There must be equal movements on both sides of the body. The child is rotating the limbs and moving the hands towards the mouth. And 5 months old child, what are the milestone that is expected by 5 months old child? The fine motor. Fine motor child, fine motor development at 5 months of age, what is the normal milestone?
Should be in the midline, sir.
What is the importance of atonic tonic neck reflex?
Tonic neck reflex must disappear at around 4 months of age for the rollover to attain, sir.
It is helpful for rolling over. And one more important milestone that is achieved after disappearance of the atonic neck reflex is bringing the hand to midline.
Okay,
and what is the importance of the disappearance of palmar grasp?
Able to grasp objects.
So 5 months old child is able to bring the hand midline, able to grasp things and with both hands. That is the fine motor milestone expected, and the rolling over is expected to be present by 5 months. Okay. So these are the important milestones. So 5 months will say that the equal movements on both half of the body, and there should not be any unequal movements, right?
Yes.
Okay, fine. Proceed.
There is no pallor, icterus cyanosis, clubbing, lymphadenopathy, pedal or presacral edema. Vitals temperature is 98.6 degree Fahrenheit. Heart rate is pulse rate is 130 per minute, regular in rhythm, normal in volume. Character, no radial, radiofemoral delay. Felt equally in all peripheries. Capillary refilling time is less than 2 seconds. Respiratory rate is 36 per minute. And abdominothoracic breathing with mild suprasternal and intracostal retractions. Blood pressure is 85-60 millimeter mercury, record in the right upper limb. Saturation is 98% in room air.
Heart rate and patient with the spinal neuromuscular problem. What is the important examination of cardiovascular system and heart rate?
Muscular causes of hypotonia, cardiac involvement will be present.
Cardiac involvement. Which type of floppy infant is associated with the cardiovascular problem?
Pompey's disease.
Pardon?
Pompey's disease.
Yes, you're right, same.
So abnormal heart rate, either extreme tachycardia, bradycardia associated with the murmurs, you have to have a suspicion of either congenital heart disease or cardiomyopathies. So patient with an unruly floppy infant having cardiac involvement, what are the differential diagnoses?
Pompey's disease, sir.
Pardon?
Pompey's disease, sir.
Pompey's disease, okay. Pompey's may be also cardiomyopathy and Pompey's then?
Myopathy is congenital myopathy.
Congenital myopathies usually they are not associated with cardiovascular problem. Mitochondrial disorders. So mitochondrial disorders, muscle disorder, muscle plus multi-system involvement, cardiac involvement, liver involvement, neurological involvement, developmental problem. So if there is anything abnormal and patient with muscular dystrophy, there may be in terminal stages, there may be cardiac rhythm abnormality. So heart rate examination is helpful in localizing the disorder as well as useful for finding out the cardiac involvement. So cardiac involvement, mainly cardiomyopathies, the form of Pompey's disease and mitochondrial disorders. And the patient with the, muscular dystrophy may have an rhythm abnormality. So that is the importance of examining the heart rate. What is the importance of examining the respiratory rate?
The status of the respiratory muscle in respiratory muscle weakness or any active respiratory tract infection.
Mm-hmm. So what are the muscles that are usually scarred in a patient with a spinal muscular atrophy?
Diaphragm is spared.
Respiratory muscle which is scarred in a patient
Diaphragm.
with diaphragm is usually scarred. Okay. Then what's the type of breathing abnormal pattern noted during the examination?
A paradoxical breathing will be present.
Paradoxical breathing is observed here, abdominal thoracic breathing and mild suprasternal and intracostal retraction. So breathing pattern is very important, right? That is indicative of intercostal muscle weakness, right? And BP is to be normal. 85/60 for a 5 months voltage. What is the range? 90th percentile or 90th percentile? Have
It is
you
under 90th percentile, sir.
under 90th percentile? Okay, right. Okay, proceed, doctor. Good, proceed.
Head to foot examination. Head appears normal in shape. Anterior fontanelle is open, around 1 × 1 centimeter. Sutures are normal. Sparse hair is present. Face, there is no dysmorphic and myopathic faces. Eyes, there is no squint, cataract, or ptosis. Oral cavity, tongue is normal. No fasciculations is seen. Chest wall, pectus carinatum is seen. Limb, there is a bilateral Achilles tendon contracture. There is no joint hyperlaxity. No neurocutaneous markers or stigmata of hypothyroidism or Down syndrome. Genitalia is normal.
During the newborn period itself, mother noticed something abnormal in the lower limb, especially around the ankle. What was the abnormality?
Sir, it was.
Are there any joint contractures noted by the mother during the immediate
Was
newborn
it a
baby.
CTEV or bilateral Achilles contracture? You said the child had some cast and all.
Yes, sir. Yes, ma'am. It looked like it was Achilles contracture only, ma'am. It didn't look like CTEV.
Nice. Okay.
Suppose a newborn baby is having bilateral CTV. What do you want to rule out? Is having bilateral or unilateral CTV. What is a neurological disorder you want to rule out? You have to rule out spinal, that is spinal trapezium. You have to rule out. That is one common abnormality which is associated with the CTEV. Especially bilateral CTEV, you have to have a strong suspicion of spinal dystrophy. For that, MRI spine is very important, right? No neurophytism of this oral cavity. How will you observe the tongue fasciculation of?
When the child was sleeping,
Pardon?
when the child was sleeping with the tongue inside, we have to look for.
How to examine the tongue of a newborn baby or an younger infant? Here you have to examine the tongue in a relaxed position. You should not order the patient to open the mouth and put out the tongue. 6 months old baby, how you have examined the tongue?
While sleeping, we can examine, sir.
For a newborn baby, how will you do examination of oral cavity? What is the method?
Putting,
You have to do some reflex test so that the baby opens the mouth and you have to use the opportunity to examine the oral cavity. That's the way to examine the oral cavity, right?
Okay, sir.
The tongue, there was no fasciculation.
Yes,
There's no fasciculation on the
no
case.
fasciculation was noted, sir.
What is the reason for fasciculation? Suppose the patient is having fasciculation in the tongue.
Denervation of the tongue muscles, sir. It will cause fasciculations.
Apparent innervation. There is a program destruction. So the muscles receives the nerve fibers from the nearby neurons. So that's why you are having fasciculations absorbed in the muscles. So commonly absorbed in why you prefer tongue as the site for examination for fasciculation?
Because the tongue, the muscles are directly attached to the mucosa, and there is less subcutaneous fat, which allows us to visualize the relation.
There is no fat. There is no subcutaneous fat at all. And prior slide, you said genitalia is normal in a floppy infant. What being a male child, what will you look for?
Testis, whether it's descended or undescended.
Yeah, very good. Anything else in the pelvis? Anything else in the hip joints?
Congenital dysplasia of hip, ma'am.
Dislocation.
Dislocation.
Dislocation of the hip joints also you have to say, okay? Other things you have covered well. And you have said there is a sparse hair. Suppose there is a sparse hair in an infant, floppy, hypotonia, but there is no history of seizures, of course. Which metabolic disorder will come to your mind whenever you see a child with a sparse hair or a seborrheic dermatitis in the scalp? It is a biotinase deficiency in which these kids can have present with the seizures at around 2 to 3 months of age. They can have hypotonia, they can have developmental delay, they can have your visual disturbances, but it is a very treatable disorder with a simple vitamin. So you should never forget about biotinase deficiency whenever you come across any infant with a sparse hair, or alopecia, or a seborrheic dermatitis. Okay? Fine. Proceed.
Hypothyroidism in the floppy infant, I will explain. Why you are specifically examined for hypothyroidism and Down syndrome? What are the other chromosomal disorders associated with floppiness? So Down syndrome, what are the chromosomal disorders which are associated with floppiness? Other trisomies also, not only trisomy 21, other
Down syndrome, Edwards syndrome.
Prader-Willi syndrome, Angelman syndrome.
Angelman, Prader-Willi.
So you have to examine all the other features suggestive of chromosomal disorders. And hypothyroidism.
You can
and
remember like this, most of these, all these chromosomal disorders will be having associated hypotonia. Name only one trisomy or only one chromosomal disorder which is associated with hypertonia. No, my dear, it is trisomy 18, your Edward. All the other chromosomal disorders will be having only hypotonia, okay? Right.
Okay, thank you. And anthropometry, the length
And one
was.
more thing, if the child had really a contractures in the ankle, then it is it is contractures at birth, is it not? Then it is arthrogryposis. Then there should have been much more findings like floppiness and all noticed in the newborn period itself. So that is always there. Bilateral Achilles contracture, you are telling. So that shows that it is a chronic pathology and it had been from in utero. Yes, proceed. Yeah, proceed.
Anthropometry measures showed a length of 63.5 against a 66 centimeter, which is at 15th percentile, which was normal. Weight was around 4.8 kg and the expected was 7.5 kg, which is less than minus third standard deviation, which is severe underweight. Head circumference is 44 centimeter, as expected again 42 centimeter, which is at 0 to plus 2 standard deviation, which is normal. Weight for length is less than third percentile, so there is severe wasting. Inference is there is a failure to thrive in this child. And this is the
What is failure
corresponding.
to thrive? What is protein energy malnutrition? Both are same or different? Here the patient length is normal, weight alone is reduced. As per your statement, length is normal and weight was found to be underweight. But weight for length less than 3, how you got on severe wasting with a normal length and underweight? Is it possible?
Yes, sir.
Secondary
to muscle wasting, there may be.
So what are the features of chronic malnutrition?
Weight will be also affected in length will be affected in chronic malnutrition. There will be
both
stunted
length as well as weight both are affected in the case of chronic malnutrition. Both length and height or length and weight both are affected. Here the patient is having weight for length more than less than 3%. Right, okay, severe wasting. So what is failure to thrive? Is there any specific definition for failure to thrive? Or can it be equated with the case of protein and malnutrition?
Since the child had calorie and protein requirement met, sir.
So what is the definition of failure to thrive? And what is the definition for short stage?
Short stage.
Child growth potential persistence below the 2 standard deviation, below the less than 2 standard deviation percentile. Or child must be showing a significant weight loss over a shorter period of time. Then only it is called as a failure to thrive.
Okay.
Persistently, the weight below the second to minus 2 standard deviation. Or there must be a significant weight loss over a short period of time. So here it is a case of failure to thrive, not a case of protein and malnutrition. Is it so?
Yes, sir.
Yes, proceed.
Coming to CNS examination, attitude was as mentioned before. Higher motor functions, the baby is alert and interested in surroundings. There is no fisting or any vacant staring or any posturing.
Why fisting? Higher motor function, why there is no fisting? What is the importance of no fisting? What do you want to confer?
Frontal release.
Pardon?
Palmar grasp, sir. Reflex, palmar reflex. Persistence of palmar reflex.
The fisting end is the disappear of. There is no fisting. Suppose the child keeps the name in a what is the fisting and what is the meaning of fisting?
Fisting occurs due to the frontal, it is a frontal release reflex, sir.
What is the fisting part?
The child is holding its thumb within the fingers.
Okay. What does it indicate? It's a persistence of grasp reflex. So beyond about 3 months, there should not be any fisting. but here there is no fisting.
It indicates there is no central cause, sir.
Right, okay, done. So no fisting means on the primitive reflexes have disappeared. What is the importance of the primitive reflex disappearance?
Persistence of primitive reflex can occur in central cause such as cerebral palsy.
Okay, it interferes with further development. All the milestones will be attained only after the disappearance of the primitive reflexes and the appearance of some corrective reflexes. So no fisting means the primitive reflex disappeared and there's no vacant step. Higher motor function, right? Okay, good. Proceed.
Cranial nerve examination. First, cranial nerve cannot be tested. Second, cranial nerve. The child is able to fix and follow bright objects, follow mother's face. Pupil bilaterally is equally reacting to light. Fundus is normal. Third, fourth, and sixth cranial nerves, extraocular movements are full and there is no nystagmus. Fifth cranial nerve, conjunctival and corneal reflexes were not done. And seventh cranial nerve, there is no asymmetry of the face.
Fifth cranial nerve, conjunctival. What is the problem doing conjunctival reflex? You should not do a corneal reflex for an infant and younger children. But what is the problem doing conjunctival reflex? Why not done? You should do conjunctival reflex. Corneal reflex alone is injurious, may be injurious. So it's better to avoid corneal reflex. Conjunctival reflex, you can actually conjunctival this way we spoke cotton. There is no problem. Right? And third, fourth, sixth, now what is the importance of examination? Third, fourth, sixth in a patient with floppiness.
It is used to determine the facial muscle involvement. In SMA, facial muscles are
third, fourth, sixth cranial. Third, fourth, sixth cranial. Third, fourth, sixth cranial.
And this myasthenia gravis, there is ptosis.
Involvement very common.
Are you expecting myasthenia gravis in this child?
No,
when you say gravis, it is an autoimmune. It is an acquired myasthenia. Okay. So you will be expecting, if at all, if it is an NMJ disorder, then congenital myasthenia. So if you say CMS or congenital myasthenic syndrome, okay, fine. Proceed. Answer sir's question. What are the other conditions that can be associated with these 3, 4th, 6th cranial nerve issues? That is your extraocular muscle involvement. What are the other differentials you will consider whenever you have an involvement of extraocular muscles with the floppiness?
I will look for, as we have said, the congenital myasthenia syndrome, congenital myotonic dystrophies, congenital myopathies.
Mitochondrial, Sarah's also initially said no, mitochondrial, congenital myopathies. These disorders will come to your mind. Why it is very particular? Why Sarah is asking this very important question? Tell me.
Because in
the
SMA,
answer should be there is no extraocular involvement in a baby with a spinal muscular atrophy. Spinal muscular atrophy will not involve the extraocular muscles. Okay, that should be your answer. Yes. Proceed.
Structures that are spot in a patient with an SMA, neuronal structures that are spot.
And the diaphragm, extraocular muscles are spot, sir.
Third, fourth, sixth, this third, fourth, sixth cranial involves unlikely and diaphragm. And what are other muscles which are unlikely to be involved, or other neuronal structures? And pelvic group muscles is uncommon, and anal sphincters. You won't get a problem with an anal or urethral sphincter abnormality and pelvic abnormality. So these are the 4 neuronal structures which supply the above said muscles are not involved in a patient with an SMA. So extraocular muscles, diaphragm muscle, pelvic muscle, and the 4th one is the sphincters, which are uncommonly involved, are not usually involved in a patient with SMA. Right? That's why the examination of the cranial is important. Yes, good, proceed.
Seventh cranial nerve, there is no asymmetry of face while crying. 8th cranial nerve, the child is able to look towards loud noises with minimal sideward movement of the neck.
So 7th cranial examination, So there are two types of whenever you are doing some, you have to observe the deviation of angle of move. There are two more type of movement. One is a voluntary movement and involuntary movement. Whenever you are doing, whenever you are smiling, that type of the pathway is entirely different. So examination of a seventh should not be done while observe, while crying and smiling, other thing. That pathway is different.
Okay, sir.
Okay.
Okay.
Is there any asymmetry of the face while crying? The pathway is entirely different. Sometimes
Okay,
it may be occurred in a patient with seventh cranial palsy, especially a UMN type of facial palsy.
Okay, sir.
Yeah.
9th and 10th cranial law, there is no pooling of secretion in the oral cavity, and there are no drooling of saliva or milk is seen. Uvula is in midline, gag reflex is present. 11th cranial nerve, a child is able to turn head minimally to side, but the child is not able to flex the neck. 12th cranial nerve, tongue fasciculations are not seen. There is no wasting or deviation of tongue.
Did you examine the throat when the child was crying, whether the palatal movements were normal? Because you said there is a feeding difficulty, child takes a longer time. Child has sometimes aspirates, has been admitted with aspiration once.
Yes, ma'am. There was no palatal, there was normal palatal movements and uvula was seen in midline, ma'am.
And 12th cranial and SMA. Is there any specific correlation? What is the importance of examination of tongue?
Mainly we look for tongue fasciculation, sir, in SMA.
So what are other things to be observed in the tongue? Examination of tongue.
In
you have to find
SMA,
out the muscle strength, you have to find out the tone and the movement. So these are the things to be observed in the tongue. Tongue tone, you have to palpate the tongue, and strength of the muscle, as well as by and movement. You have to observe. And is there any fasciculation? And what are the pediatric conditions which are associated with 12th cranial palsy? One such is SMA. Is there any other condition which produces a 12th cranial palsy? Patient with a CV junction anomaly or patient with the foramen magnum lesions are associated with the 12th cranial palsy. And 11th cranial palsy in a pediatric condition include the patient with a muscular dystrophy, especially with the myocardial. Patient is having a neck muscle weakness, that is 11th cranial weakness. So these are the importance in relation to pediatric age group and cranial examination. Let's proceed.
motor examination, the bulk muscles appear visibly wasted symmetrically, and the muscles are soft and flabby to touch. Tone, on palpation, the muscles are flabby, and the passive movements, when passive movements are done, the range of movements is increased, and there is decreased resistance to passive movements. There is increased floppiness of the limbs.
What is the active tone? What is passive tone?
Sorry, sir.
What is the active tone? What is the passive tone?
Active tone is passive tone is what we move and find, sir. Passively
Range of
moving.
movement possible is a passive tone. Active tone.
Active
The
tone is the
resistance
decreased
of the passive movement. Going passive towards a muscle tone, you have to observe. That is an active tone.
Okay, sir. Okay, sir.
Okay, yes, good. Proceed.
Since it is a hypotonic infant, the 180-degree flip test was done. On pulling up the child, there was complete head lag as seen in this image.
What does it indicate? Head lag indicates, is it due to weakness or due to hypotonia?
That is due to hypotonia, sir.
It's not due to, it's due to muscle weakness. So head lag is always due to muscle weakness, not due to hypotonia, right?
Neck flexor weakness.
Okay.
Okay. Right. Next.
When the child was made to sit, there was rounding of the back was seen. On ventral suspension, on vertical suspension, the child was slipping through the hands and there was no scissoring seen.
The 5 months
On
old child, you are pulling to sitting position. So what is normal of 5 months old child? What are the normal things? And in the child, what is lacking? You have to mention. So 5 months old child, while you are putting the baby to sitting position, what are the normal things to be observed and what is abnormal in this position? 5 months old child, you are now making the baby to sitting position.
while pulled to sit, while pulling to sit from supine position, there will be complete neck control on swinging side to side, and the back will be straight, sir.
Okay. And sometimes when the baby assumes entire sitting posture, there may be head fall. There may be normal 5 months old until the child attains and trunk muscle control. So 5 months old child, while you are putting the baby to sitting position, that's complete head control, is able to maintain head along the body and the terminal position. Sometimes there may be fall of the head somewhat anterior, somewhat forwards. But here the child is in complete head flat.
Yes.
And when the baby is having and what the appearance of the back is having rounded appearance. Is it so? Yes.
Yes, sir. Spinal curvature is present.
I talk good. Proceed.
On ventral suspension, as seen in the rightmost picture, the baby assumes a ragdoll posture with complete head lag, and the baby does not attempt to lift his head. On prone positioning, there is no spontaneous attempt to lift.
Upper limb and lower limb, what is the position? Head control, complete head control.
And upper limb and lower limb are hanging loosely, and
there is no active flexion in the upper limb as well as the lower limb. That is an U-shaped infant is called as floppy. When you keep the baby in a ventral suspension position, the baby assumes an U shape. There is complete there is upper limb, there is one muscle.
அப்படியா சரி அப்ப நீ உள்ள உட்காரு நான் வண்டியை தள்ளி விட்டுட்டு வரேன்.
And lower limb is also there is no muscle movement at all. So that is the future of a floppy infant while keeping the baby in a ventral suspension. What is vertical suspension?
Child is when we lift the child vertically by holding under the axilla, under the shoulder, the child will feel like the child is slipping through the hands.
Okay, right.
But you have to lift the child, my dear. You cannot keep the child's lower limbs on the bed. You have to lift the child from the bed. Okay. Then only you can see the lower limbs, how the lower limbs are there. Are they floppy or not? Are they moving whether the child is moving the limbs actively, or you can in this particular child being a floppy child, there are no active limb movements in the lower limbs. You have to say. Yes.
So the impression is there.
And the another thing is from this examination of the tone, by inspection, by palpation, by doing your by inspecting the active movements as well as by examining by passively moving the limbs in the joints, examining the passive tone, and by doing this 180-degree flip maneuver, what is your inference?
The inference is there is severe hypotonia, ma'am.
Yes, number one. Number two is whether the axial tone and the appendicular tone is involved or not. Is there an axial hypotonia? Yes, the child is slipping through the fingers. So there is an axial hypotonia. Is there an appendicular hypotonia?
Yes, ma'am.
By what it means is that there is an hypotonia in the limbs as well. Not only in the axially, but also in the limbs, in the appendix, in the limbs. So whenever you have an axial as well as an appendicular hypotonia, you have to consider a peripheral cause rather than a central cause, in which there will be an axial hypotonia only, but not appendicular hypotonia. So in this way, this examination is useful for you to deduce whether it is a central or a peripheral cause. So, proceed.
Hamiltonson angle was measured, and all the and adductor and popliteal angle was increased more than the normal range, but the dorsiflexion angle was normal, probably due to the contracture. The scarf sign was also normal for the age. Coming to power, upper limb in the proximal, the child was able to move the limb only along the gravity. So the power was 2/5. Distally, the child was able to bring his forearm to the mouth, and so there is against gravity movement. So the distal power was 3/5. In the lower limb, the child was able to move the limbs along lower leg along the bed. So the both the proximal and distal was 2/5. Palmar grasp was
But elbow movements is not distal. So you have to mention as shoulder 2/5, 2/5, elbow 3/3, 3, and you can say palmar grasp or your hand grip or hand grip is weak. In the lower limbs, hips 2, 2, knee 3, 3 or 2, whatever it is, whatever you have examined, and in the ankle, since there is a contracture, is there any movement or not, and whether the toe movements are full. Okay. Next.
Palmar grasp was present, but it was weak. And coming to the axial skeleton, axial musculature, the child looks towards the side with minimal neck movements, and there is no truncal movements. So the impression.
Present by 5 minutes. Tamira, at what age you the problem disappears?
It disappears around 4 months or 3 months of age, sir.
So it is better you mention it as a hand grip.
Hand grip, okay.
Okay, and you have to say rather than child looks to the side with a minimal neck movements, you have to say neck muscle weakness plus trunk muscle weakness plus present.
Okay. So the impression is there is generalized weakness involving both the axial and appendicular musculature. Proximal more involved than distal, and upper and lower limbs more involved than upper limbs.
No, all the according to your finding, it is all the 4 limbs are involved. There is no preferential weakness. We accept that the proximal is more.
Yes, Coming to the reflexes, superficial reflex, corneal conjunctival reflex was present. Abdominal reflex was absent.
There should never be any discrepancy in your presentation. Earlier you said I have not examined. Now you are telling that it is present. Okay.
Abdominal reflex was absent. Cremastic reflex was absent. Plantar reflex showed bilateral extensor response. Deep tendon reflex, all the deep tendon reflex were absent. No primitive reflexes were seen.
Plantar bilateral extensor, is it normal for this age?
Yes, sir.
Okay, this is expected. And what does India cremastic reflex abdominal reflexes absent? That is the pathology.
Lower spinal segments.
Absent superficial reflexes indicate the pathology. Absent abdominal reflexes, right? And deep tendon reflexes absent or depressed.
Absent, sir. Totally absent.
Absent. So, what is the importance of absent or
It
depressed or retained deep tendon? How it is helpful in localizing the lesion?
In a peripheral cause in anterior horn cell, the reflexes are absent. When
to define the neurological weakness into myopathy weakness or neurological weakness. So myopathies, what about the deep tendon reflexes? And what about the neuropathies?
Myopathies, the reflexes
are usually retained but not completely absent. Whereas in a patient with neurological weakness, the reflexes may be absent or very much depressed. But absent deep tendon reflex always pathology, right? So that is an importance of the deep tendon reflex examination. And primitive reflexes they are okay, right? Yes, proceed. Even primitive grass reflex presence for contradicting your own statement. Not you have mentioned the patient having a palmar grass still persistent.
Seeing when offered objects, the child is able to grasp the object. I was saying that.
The method of assessing muscle power. Reflex is different and assessment of muscle power is different. Suppose the 2 months old, they hold infant. How to examine the muscle power of upper limb, proximal muscle and distal muscle. The 2 months old newborn baby. How to examine the proximal and distal muscle of an upper limb. You have to do some reflexes. You can observe the proximal muscle weakness. So by doing
Sir, your voice is
distal muscle
getting.
weakness. The same thing.
Hello.
So grass reflex the younger infant. Okay.
டாக்டர் பாபுக்கு தக்கமாற நீங்க உங்க வாய்ஸ் விட்டு விட்டு வருது சரியா கிளாரிட்டி இல்ல.
Okay. Shall correct, no problem. Right.
Shall I proceed, sir? Shall I proceed, sir?
Yes, sir. Proceed.
Sensory system, the child is able to perceive, react to touch and pain, reacts to cold temperature by crying. Cerebellum, there is no nystagmus. Spine and cranium appears normal.
Spine and cranium என்ன abnormalities பண்றீங்க?
Cranium, there may be abnormal shape of the skull.
Okay.
Plagiocephaly,
Okay.
microcephaly, macrocephaly. In spine, there may be any spinal dysraphism, any tuft of hair, spinal dimple may be seen, sacral dimple may be seen.
Is there any scoliosis or kyphosis? Are commonly observed in a patient with some neuromuscular junction weakness and myopathies and SME. So you have to observe the spinal column, the form of either a kyphosis or scoliosis. Yes, okay. Yes. See.
Other system examination showed a respiratory system, the work of breathing was normal, and bilateral air entry with present with normal vesicular breath sound. Cardiovascular system, normal heart sounds were heard, no murmurs. Abdomen was soft and no acromegaly was seen. Umbilical was normal. External orifices were free. External genitalia was normal. Musculoskeletal system, the hips were stable. There was a bilateral Achilles tendon contracture was present. Examination of the mother showed no features of myotonia, no ptosis or myopathic feces, no grip or percussion myotonia.
Very good. I appreciate you, my dear, for examining the mother as well for all these findings. Very good. So to summarize.
So a 5-month-old boy baby, second born of third degree consanguineous marriage with signs of generalized symmetrical hypotonia and weakness, more in the proximal, with respiratory muscle involvement and weak cry, with sparing of facial muscles and with feeding difficulties. The child has areflexia and cognition is intact. There is also failure to thrive, and child also has Achilles contracture. The social language and visual milestones are appropriate for age. So the probable diagnosis may be a spinal muscular atrophy. And I will also like to offer some differential diagnosis. Congenital
When muscle power, you have to explain the neck muscle as well as the respiratory muscle.
Yeah.
Not only you have to explain the limb muscle power, you have to also explain the respiratory muscle power. How will you examine the respiratory muscle power? And you have to examine the neck muscle power also, both flexion and extension. There's one small correction.
Yes,
You not
sorry.
mention the respiratory muscle. What are the best state tests to assess the respiratory muscle power?
Respiratory muscles, sir. Respiratory muscles
For
in
the older children, how will you
older
assess the
children,
respiratory muscle power?
a single breath count test can be done, sir.
Okay, then.
That is for an older child. So here is an infant. So how will you examine for the intercostals and how will you examine for the diaphragm? That's what I is asking.
We could determine the power by the cry of the baby.
Okay, cry indication or the tidal volume. Okay, then. Splinting, what is by splinting? Suppose you are doing splinting. What are you observing? Splinting the chest, you can observe the muscles of the abdominal muscle of respiration. And by splinting the abdomen, you can observe the muscle power of intercostals. That's the only of assessing, and other test by noting the respiratory chest wall movement as well as the volume of prey. You can assess the respiratory muscle power. And neck muscles also you have to both flexion and extension. By doing some reflexes or by holding the baby, you can assess muscle power and neck muscle. So these are the two important muscle power to be included in the muscle power exam. Other things like examination of motor system and sensor systems are okay. And the examination of other system, abdomen, there's no organomegaly in the patient lab.
No,
CV
sir.
is normal.
No, so there's no organomegaly, sir.
Okay, all right. Okay. What is important organomegaly? Suppose this patient, floppy infant, having
Storage disorders can be suspected, sir.
pardon?
Storage disorders can be suspected.
In a storage disorder present in the form of floppy infant. Yes, correct. Okay.
G1 gangliosidosis.
It's not glycogen storage disorder. Pompis disease presenting in younger
Yes,
infant.
they can have an hepatomegaly, no?
Hepatomegaly and other neurodegenerative disorders, especially the mitochondrial disorders and felicitious muscular disease presenting with both hepatosplenomegaly and neuromuscular hypotonias. So importance examination of abdomen, the presence of hepatosplenomegaly. Right. Okay, good. Final diagnosis.
Final diagnosis, SMA, probably early infant type of SMA, sir.
What is
Why
the
do you
type of
say it's an SMA? So your first diagnosis is SMA. So
Yes, ma'am.
substantiate your diagnosis.
So the child is a floppy, weak child with facial muscle sparing, and the cognition is also intact with the social.
With the weakness of all four limbs, you have to.
So what you have to say is here is a flaccid quadriparesis of pure motor weakness with no sensory, with intact cranial, with intact sensorium or intact higher functions, and there is no associated seizures, microcephaly, dysmorphism, and there is an axial as well as appendicular hypotonia. Because of all these things, we are considering a peripheral hypotonia rather than the central hypotonia. So among the peripheral hypotonia, since there is no sensory involvement with the predominant proximal weakness with absent reflexes, I am considering an anterior console disorder and it is a chronic problem. So in this age group, I am considering a spinal muscular atrophy, as you have rightly pointed out, most probably a Wernicke-Hoffmann disease or an you can say an early infantile form of SMA, or you can say it is an SMA, most probably an SMA type 1, as the child has not achieved even the head control. Okay?
Okay, ma'am.
Other things are again differentials. You can the first differential diagnosis which for any floppy infant you have to offer is metabolic myopathy, namely the Pompey's. Why? Though the reflexes are absent, everything is there. Because it is treatable, ERT is available. Okay, so you have to consider metabolic myopathy, namely the Pompey's as the or glycogen storage disorder, or Pompey as the differential. Congenital myopathy, you can say congenital muscular dystrophy, congenital myotonic dystrophy. For all those things, you should have an dysmorphism. You can have other findings. You will have cranial musculature involvement. Again, for congenital myasthenic, of course, you can say, but your differential diagnosis will be one is metabolic myopathy, but two is congenital myopathy. How will you proceed? Say fast.
Coming to investigations, initially, since I suspect a peripheral cause, I will proceed with the creatine kinase. And by the side, I will also do basic other workups such as serum electrolytes, serum calcium, to rule out any cranial abnormalities or malformation. MRI brain will be done.
Whenever you say serum CPK, then you have to say for your first diagnosis, will it be normal or increased? The
In
answers
spinal
also you
muscular,
have
it
to
will
say.
be normal, ma'am.
Yeah,
In
my first investigation will be serum CPK, which will be normal in this child. Whereas in other things like in congenital myopathy also it can be normal. Whereas in congenital muscular dystrophy, it will be increased. That will be CMD. It will be increased. Yes. In metabolic myopathy also it will be increased. Next.
Next, for confirming if I suspect SMA, I'll first line investigation is
The next
ML.
investigation will be your cardiac evaluation and X-ray chest. If it shows a cardiomegaly, then it is not an SMA at all. Then you will be thinking in terms of a Pompey's. So your next investigation will be an X-ray chest. If possible, if the X-ray is normal, then you can leave. Otherwise, you have to go for an echocardiogram. Okay. Then the third only will be even in your child is having some amount of respiratory distress, your intercostals working, so associated X-ray chest will reveal you whether there is any associated pneumonitis patch and all. These things you have to look for. Then
Confirming after that, we can do electromyogram and nerve conduction studies, ma'am.
not necessary, because you have localized that it is a peripheral hypotonia. You have localized that it's only an element disorder, and among the element you have considered only anterior console as your possibility. So your first possibility is SMA only. You are not clinically, you are not in a dilemma whether it is an anterior console or a muscle, because your reflexes are absent. There is no dysmorphism. There is no myopathic phases. Child is having an intact higher mental function. Child is conscious, alert, looking at you, smiling at you. So in that circumstances, you are thinking SMA only. So in such circumstances, EMG is not necessary. Okay. So you can suppose your sensations are involved. You have a sensory involvement, then you can proceed with an NCS, nerve conduction study. Suppose you have an extraocular muscle involvement, then if you are thinking in terms of a neuromuscular junction problem such as your congenital myasthenia, then you can proceed with your nerve conduction study, especially repetitive nerve stimulation. Otherwise, this electrophysiology is not, that is your NCS or your EMG is not necessary. You can straight away proceed with the genetic testing. So now tell me, considering SMA as your first possible diagnosis, what test you will order?
I will order MLPA, ma'am, multiplex ligand dependent probe assay.
For
to look for any deletions in the SM1 gene in exon 7.
SMN gene. What is SMN gene?
SMN1 gene, survival motor neuron gene.
Very good. Not only in one. Is it sufficient that you do it in SMN1 alone?
We
of
can
course,
also
for diagnosis, yes.
To look prognostication, to look for the number of SMN2 copies, ma'am.
So it is better that you do MLPA for SMN gene deletion. That's what should be your answer.
What is the role of SMN2 gene?
SMN, when we
every individual with an SMA. What is the role of SMN2 gene?
Since in SMN1 gene, there is a homozygous deletion, SMN2 will compensate for
SMN2 gene. Is it present in every individual with SMN?
Yes, sir. It will depend depending upon the copies. There is phenotypical classification of SMN, sir.
What is the end product of an SMN2 gene?
It produces
SMN2 number copy gene.
SMN2 gene.
It also synthesises a protein which is very similar to the SMN1 protein, so that it compensates the deficiency of SMN protein. So the patient with the SMN1 deficiency, if there is a sufficient number of SMN2 number copy and with the minimal deletion of SMN1 gene, patient can have near normal and something abnormal or not completely abnormal. So SMN2 gene copy number is very important in patient with the minimal deletion. So you have to find out both That's the ultimate diagnostic test. SMN1 gene and SMN2 copy number. Right?
So it explains you the severity of the disease.
And what is the importance of ECG? Is it helpful in making a diagnosis of anything abnormal?
So sorry, sir.
Apart from cardiomyopathy, how it is useful in diagnosing SMA?
ECG, sir. Sorry,
You can
sir.
find out the muscle fasciculation by taking an ECG.
Okay,
You
sir.
can also find out an artifact which is suggestive of muscle fasciculation, which is contributing contributes for diagnosis of SMA.
Okay, sir.
Right?
Okay, sir.
Okay.
Coming to management,
Suppose the patient is having equivocal or negative genetic marker. You are doing the genetic test, it's going to be negative or equivocal, then how will you proceed? There is one scenario. Sometimes the genetic marker may not be positive or not contributory or not final diagnostic. Then how will you proceed forward?
if there is no expected result in MLPA, I may proceed with clinical exome sequencing to look for any point mutations.
So the genetic marker study is not contributory. It's equivocal or negative. Is there anything, any investigation? What is the role of muscle biopsy? Is there any role in muscle biopsy?
Yes, sir.
In doubtful cases, you can do a muscle biopsy and some of the findings of peripheral denervation findings. You can substantiate the diagnosis of spinal muscular.
Okay, sir.
You should know that for spinal muscular atrophy, simple muscle, that is your muscle biopsy with the H&E staining, that is your hematoxylin and eosin staining itself is sufficient. There are no special stains needed for diagnosing spinal muscular atrophy.
Okay, ma'am. Shall I proceed with management, ma'am?
Only thing what you have to say is muscle biopsy can be done, but if it is negative for spinal muscular atrophy, there is no group atrophy, or as sir has pointed out, there is no neurogenic atrophy, then the other differential diagnoses have to be ruled out. For them, special stains are necessary. Number two, it is an invasive procedure for which anesthetic you can't do it under local anesthesia. For such a small child, you need to give a general anesthesia. So getting an anesthetic fitness becomes difficult. Suppose the child goes in for an respiratory failure, then the child will be hooked on to a ventilator. Then getting out of the ventilator will be difficult for these children. These things you can propose, but you have to always say that the muscle biopsy is an option. Is a test which can be done to confirm the diagnosis. Okay. And you should know in SMA, that is whatever we are talking about, this one SMA, type 1, type 2, type 3 are called 5Q SMA. Okay, there are something else called non-5Q SMAs. So this group is called 5Q SMA or proximal SMA. Among the proximal SMAs, it is 5Q SMA. And this 5Q SMA only can be diagnosed by your MLPA. So for other type of disorders, there are other genetic mutations which can be identified by your whole exome sequencing. And again, congenital myopathies, congenital muscular dystrophies, congenital myasthenic syndromes, all those things can be identified by your whole exome. But still, suppose, as Sir has pointed out, if it comes as uncertain significance or inconclusive, then it becomes difficult. In such a scenario, then muscle biopsy will give you an answer. Except for CMS, other diseases, muscle biopsy, various types of congenital myopathies, muscle biopsy will give you an answer. Again, metabolic myopathies, your Pompe's disease, it is glycogen storage glycogen will be seen in the inside the muscle cells. In your PAS positive stain, again, mitochondrial myopathy can be diagnosed by your muscle biopsy. Suppose if you are considering CMD, that is your congenital muscular dystrophy, as a possible differential, then you may have to do an MRI brain, in which you will be looking for neuronal migration defects. Apart from that, for the other things, CNS is not involved, so you need not go for a imaging, neuroimaging of the brain at all. Okay? Right,
Okay, ma'am.
management.
Management, that if there is any emergency measures, we have to tend to that. Mainly supportive therapy and specific therapy. Supportive therapy, physical rehabilitation with physiotherapy to prevent contracture, to increase the strength of the muscle, and supportive therapy for any feeding problems. NG feeds NG feeds can be initiated in case of feeding issues.
There is something called a standard of care management and there is something called a specific management. So standard of care only you are telling now. So physiotherapy you will be doing. Next is you have to attend to the nutrition. Third will be about the feeding issues, whether the child is not able to swallow or has some aspiration, frequent aspiration, then you may have to go for NG feeding. For a longer period, you can't keep an NG feeding. In such a scenario, you may have to go for a
gastrostomy.
Yes, feeding gastrostomy. Then
specific treatment. It's
another thing is prompt and proper immunizations have to be given so that you can avoid so many infections. That is also comes under your standard of care. Then
Respiratory support is
X-ray
very
or
important.
yes, respiratory support. Yes.
Only
Whether
for
a
the
child
respiratory.
needs a BiPAP and all, you have to identify. So you have to get a pulmonologist opinion and check whether child needs any respiratory support. Other things, you may have to do an ultrasonogram abdomen, ultrasonogram pelvis, including both the hip joints or X-ray hip joints to find out whether there is any dislocation of the hip. And as the child grows, then you may have to periodically monitor the child's spine, as these children are prone for scoliosis. Hence, you may have to take an X-ray dorsal spine. Yes.
Specific treatment.
Can I proceed to specific management, ma'am?
What are the things available? You have to know. What are the things which are available in the world? Yes.
Mainly there is nusinersen, ma'am, which is a antisense oligonucleotide. It can be injected intrathecally. These specific treatments are mainly for type 1 SMA. The other one.
No, it's not like that.
Another one where gene therapy is available, ma'am. Adenovirus vector-based gene therapy,
which is
which
said
is a
to be
which can be
replacing the deleted exons. So that is gene therapy, which is given as a one-time intravenous infusion. And the indication is
type 1 SMA, ma'am.
No, it's less than 2 years age.
2 years age.
Beyond 2 years, this gene therapy is intravenous gene therapy is at the present moment, it is not indicated. It is less than 2 years of age. Okay. Regarding the next thing is what you are doing is by giving antisense oligonucleotide, as Sir has pointed out, you are improving the SMN2 things. That is by giving ASO, you are improving the SMN2 levels or SMN protein secretion of the SMN proteins. So that one is on your intrathecal nusinersen. Another one is oral risdiplam. Yes.
Some of the oral substances are also available, which in turn improve the SMN2 protein synthesis. Some substances like RG and LM with some numerical numbers that are found to be useful. They can be given orally. All induces the synthesis of SMN2 protein by including the 7 exon in the SMN2 gene. Thereby, these drugs are found to be useful.
Suppose if you are thinking in terms of, and suppose there is some cardiomegaly in this particular child, then your diagnosis will be an glycogen storage disorder, namely POMP, for which what investigation will you do? What is that enzyme which is deficient in POMPs?
A-glucosidase enzyme, ma'am.
Yeah, it is acid maltase. So immediately you have to go for a DBS for that enzyme assay. Because your ERT is available, then because of that, you have to do this enzyme assay and proceed further. Okay. Anything else for CMS? Because only the treatable disorders we may have to know.
Okay.
For congenital myopathies, we are not going to do anything. So it is only the standard of care. For CMS, congenital myasthenic syndromes,
It is
for whole
still
exome sequencing can confirm the diagnosis. That is the only possible way.
Genetic
So for
counseling.
those things, we can give pyridostigmine. Certain congenital myasthenic syndromes will respond to pyridostigmine. For some of them, it is contraindicated. Your beta agonist, your salbutamol, albuterol, ephedrine will be useful. For some of the CMS, it is quinidine, fluoxetine. Okay, so these drugs can be used for congenital myasthenic syndromes. So apart from that, you have
What
a
about
failure to
genetic
thrive,
counseling?
so you may have to consider your nutrition assessment, everything you have to say.
How to
Yes,
prevent
sir.
inflammation from genetic counseling?
Yeah, that is the most important thing. Unless otherwise you mention about genetic counseling, this is not your management is not complete.
Yes.
Now tell me, what is the mode of inheritance for SMA? How will you counsel this mother?
The mode of
Did you
inheritance is
examine the first child? You have examined the mother, very good. Did you
autosomal.
examine the first child?
No, ma'am. According to history, the child is normal, ma'am.
Mm-hmm. Was there any history of abortion in between and all? No.
No, ma'am. No, ma'am.
Mm-hmm. Okay. Now you have to counsel the parents.
It is SMA is autosomal recessive condition. Attenders
Risk
will
of
be
recurrence.
Risk of
What is
recurrence.
the risk of
25%
recurrence? What is the incidence of
affected.
carrier state?
50%, sir.
What is the incidence of carrier state? Suppose in
50%.
general population, not 50. The carrier state in the general population, what is the incidence? It's 1 in 40 to 1 in 60. So very, very, very common.
Very
Second one is
common.
cystic fibrosis, very common. So you have to do a screening for the parents, and if anything previously affected, you got to do a genetic analysis and find out the genetic abnormality. And the subsequent pregnancy, you have to do a chorionic biopsy at the earliest by 10 to 12 weeks of age and find out the genetic marker. If there is something abnormal, then you have to advise the parents regarding the possibility of getting the disease in the subsequent sibling also. So genetic counseling is very important. Why you are giving very much importance to this group of patients? There is now at present there is not treatment is not said to be curative for the condition in our setup. So we have to prevent in future siblings. So genetic counseling is very important. Okay?
And
And
this risk of
other
recurrence also, you
example,
have to say each child is having a risk of 25%. Okay.
Okay, ma'am.
is there any neonatal screening program for
SMA?
SMA?
No,
And
sir.
what are the samples that can be tested for SMA gene analysis? Common and sample you can analyze. In peripheral blood, you can do the WBC analysis and muscle biopsy and chorionic ulcer. These are the
Biopsy or even amniocentesis. Amniotic fluid also, you can do the same genetic testing to identify the mutation.
Okay, ma'am.
Then they may ask you about SMA types. So Werning Hoffman, you have to remember everything. Here is a classical child with who presents with the clinical features of Werning Hoffman. So this from this case itself, you can read. If you read, then you will remember it very much nicely. And then type 2 is age of onset is, for type 1, it is 0 to 6 months. For type 2?
For type 2, it will be after 6 months. 6 months
6 to 18 months. Certain things you have to study, my dear. So 6 to 18 months, it is type 2. What is the other name for type 2?
Kugelbeck-Walland.
That is type 3, da? Type 2 is Dubowitz. Okay. And the type 3 is after 18 months, it is only called a Kugelberg-Villander. There is one type 4 which has an onset during the adult period. Okay. And the next thing which you have to remember is type 1 will never achieve head control. Type 2 is sitters, they can never stand or walk. Whereas type 3, they will walk. They can stand and they can walk. Okay. These things,
What is
these
the
are the
long
small things you have to remember.
What is the survey? Present available treatment. How long the patient can survive?
Babu sir, you are not audible.
Type 1 SMA, what is the longevity of the patient? How long the patient can survive with the present available treatment?
Type 1 less than 6 months, sir.
The type 1 up to 2 years life can be maintained.
Whatever the literature says only you can say, my dear.
2 up to 2 years. And type 2 patient can survive up to early childhood. And type 3 patient can survive into even adulthood. What is type 4 SMA? There is one more SMA which is observed in the adult also. So you should know the various age of presentation of different types of SMA. And what are the common cause of death?
Respiratory
Common
failure.
cause for respiratory failure. Another
Respiratory failure, sir. Aspiration.
aspiration, frequent respiratory infection, nutritional abnormality, and hypoxia. Hypoxia is it common to have hypoxic episode in this group of children?
Yes, sir.
Hypoxic episode can also occur because of respiratory problem, and they are prone to develop hypoxic episode. It can interfere with the neuronal structures also. So cardiac abnormality, hypotension, and these are the cause of death, not only respiratory problem. Yes, now you can conclude. So the time is already passed beyond 9:30.
Thank you so much, sir. Thank you so much, Dr. Sanjeeva. Babu sir, may humbly request the President Dr. V.T. Rajesh sir to have thanks to our honorary professors, Dr. Babu Kandakmar sir and Dr. Hema Palit madam sir.
Good evening once again. Thank you, Lima Pauline madam and Dr. Babu Kandakmar for sitting such a long time going through each and every point of the case and discussing elaborately. I thank you once again. I thank all the central OBs, EBs, state office bearers, and all the students, as well as all the IAPNs and senior pediatricians who are there sitting all through and going through the case. Thank you very much.
Thank you, Lima.
Thank you, sir. Thank you very much. And good Sangeevita. Good, nicely, Sanjeevita. You have nicely presented. Good, my dear.
Sorry, sorry, Lima Pauline. 9 o'clock வரைக்கும் சொன்னீங்க கொஞ்சம் டைம் எடுத்துருச்சு பட் ரொம்ப
No problem, sir. Thank you.
awesome. Very awesome. Thank you.
Thank you, madam.
Thank you, sir.
On behalf of IAP
Thank you, Dr. Lima Pauline madam.
Thank you, sir. Thank you, Babu sir.
Thank you. Thank you, the organizers, for giving the opportunity. And the student has presented very nicely and answered most of the questions. And congratulations to her and the team of IAP TTP chapter. Thank you very much, and good night.
Thank you,
sir. On behalf of IAP TTT, we wishing all the very best to Dr. Sanjeevita and all the postgraduates attended the meeting for not only for the exams but also for a successful career again. Before we conclude, we'll have a vote of thanks from our moderator, Dr. Anand sir, and then we can conclude the meeting, sir.
So it was a very enlightening session, and the case was very well presented and was discussed very well. So I thank Dr. Lima Pauline madam and our own Dr. Babu sir for having dealt with the case in a very excellent way. So thanks one and all. So we'll have such meetings in the future as well. Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you so much, sir. With this, we are concluding the meeting. Thank you so much, everyone who